Right. Hi, everyone. Good evening, and welcome to today's endocrine exam lecture. We're really lucky to have Dr. Morris with us. For those of you who don't know who Dr. Morris is, she is an incoming FY1 doctor, or a junior doctor to most people in most countries, and she'll be starting in the south of England in the coming weeks. And we're incredibly excited to have her lecture for us today. So if you wouldn't mind just moving on to the next slide.
Yeah.
And then the following slide, please. And yeah, and just a really quick one before I let Dr. Morris get her talk underway. So as many of you already know, we have a really nice and generous series giveaway. So as you guys can see that there are two different prizes. Prize one is, or it includes a Oxford Handbook, QuesMed, single-based answer question bank access, and also a os implant skull. And our second prize is a suturing kit from My Suture and Podcases by Scrubbed In. And it's incredibly easy to sign up and register into this draw. So at the end of this lecture, you have to fill out the feedback form, which is obviously very important to Dr. Morris and to us as an organization to find out where we can improve. And the more lectures you attend, the higher your possibility of winning one of these two incredible prizes. And just before we start, I would just like to once again give a big thanks to all of our partners at the bottom. So that's Scrubbed In Podcases, os Implants, My Suture Kit, QuesMed, Anastomose, which we use to advertise all of our educational events, and Medal, lastly, the service which provides us our feedback and all of your certificates as well when you complete your feedback form. So yeah, that's all from me. Sophie, thank you very much for joining us once again, and yeah, you can take the floor, please.
Great, thank you. Let's just yeah. So yeah, as mentioned, this will just be covering your sort of endocrine examination. So just a quick overview, we're just going to cover some sort of general inspection points, sort of common signs that you might see in different endocrine conditions. We'll cover thyroid examination and also diabetic foot examination. I've sort of set time aside for questions at the end, but if there are any questions that sort of pop up while I'm speaking, just pop them in the chat and I can answer them as I go. And then we've got a few questions sort of spaced throughout the presentation. So if you could just put any answers you have in the chat for that as well, then we can discuss the answers. So I just thought I'd cover quickly your sort of key points that you're always going to do at the start of any examination. So obviously at the moment, sort of washing hands and PPE if needed. You'll introduce yourself and what your grade is. You'll confirm the patient name and date of birth to make sure that you're checking the right patient. You'll give a brief overview of the examination so the patient knows what they're sort of consenting to. You'll then gain their consent and just before you start to make sure they're properly positioned, always making sure you sort of move the bed up and that kind of thing, which will make your examination easier and more comfortable for you to carry out. So just to start with a general examination. So always start at the end of the bed. You just want to sort of give yourself a general overview of the patient. So I've just covered a few things here, which I think are sort of good to note. Sort of, you're obviously not going to make any diagnoses off this, but it's good to just sort of slightly be aware of. So sort of look at their height. Are they short or are they tall? I've just put a few differentials in there. So sort of short height, you're thinking growth hormone deficiency or something like Turner's or Noonan's. If they're very tall, are you thinking acromegaly? Are you thinking gigantism? Or are you thinking something like Klinefelter's? There are lots and lots of different differentials for short height and tall height, and sometimes it can just be sort of based on their family or other factors. But again, it's just something that you should sort of start to bear in mind. Also, just looking at their weight. Do they look sort of a normal body weight? Do they look low weight, which might indicate something like hypothyroidism, or have they got quite a high body weight where you're thinking hypothyroidism, Cushing syndrome, or something like diabetes? And then this one's a slightly trickier one, but just looking at their body shape. So you've got the sort of classic Cushingoid appearance, which is sort of truncal obesity or sort of lemon on a stick, which is the way sometimes people describe it, and other factors like a buffalo hump. And then a condition such as acromegaly, they can get very large hands and feet and quite coarse features. So this is just something that you should sort of subtly take in just as you're starting the examination. This isn't something that you're going to make a diagnosis of, but just something to sort of just slowly add to your list of differentials. So I have put observations in here. Observations wouldn't normally be part of your examination, but I do think generally if you're going to examine someone in hospital, you would look at their obs charts, and that would also just help to sort of aid your differentials. If they're tachycardic, then you're thinking hypothyroidism, or something quite rare called pheochromocytoma. If they're bradycardic, then you're thinking hypothyroid. There are quite a lot of endocauses of raised blood pressure. So it could be something related to parathyroid hormones, something related to cortisol or aldosterone, and then also their temperature and their sort of skin temperature. So if they're quite warm or clammy, then that could be hypothyroidism, or if they're kind of cold, dry skin, you're thinking hypothyroidism. So again, this wouldn't be part of your classical observation, but something that would sort of add to it. So first question, what condition can cause enlarged supraorbital ridges? Just type your answer in the chat. So supraorbital ridges are your area here. So there's an endocrine condition that can cause that.
So someone is saying acromegaly.
Yeah, absolutely, that's right. So yeah, this is just your start of your general inspection. So I always like to do a sort of top to toe work through, so you make sure you don't miss anything. So just starting with the face, and that's absolutely right. Acromegaly causes enlarged supraorbital ridges. As mentioned previously, it can also cause sort of coarse facial features and a large jaw. In conditions such as Cushing's, they get this sort of plethoric face. So can you see my mouse?
Yeah, we can see the mouse.
Yeah, great. So this image here, sort of quite a rounded face, and she's got sort of erythema on her cheeks, so sort of a plethoric appearance. If they've got a condition that's causing raised androgens, then that can cause hirsutism. So this sort of coarse facial hair, obviously relatively difficult to diagnose in men because that's more normal for them, but in a woman, if you see sort of this facial hair, then you might think that it's something to do with their androgens. And then this final sign is a relatively rare sign, but something just always useful to be aware of. It's called Queen Anne's sign, or I'd never heard of this, but a sign of Hurtoi. So this is where you lose the outer third of your eyebrow, and it can be an indicator of hypothyroidism. So those are things that you should be looking out for on the face. You wouldn't always say them as sort of negatives, but just useful things to be bearing in mind just when you're looking at the face. Okay, next question. Which part of the optic tract is affected by a pituitary mass? And what kind of visual field defect does it cause?
The optic chiasm.
Yeah.
And someone is saying bitemporal hemianopia.
Perfect, yeah. That's absolutely right. So yeah, so we've done the face, so now moving on to the eyes. So as just mentioned, a pituitary mass, it compresses on the optic chiasm, which is 0.1, just on this diagram here, and that causes the bitemporal hemianopia. The main sort of factor that you're trying to look for in the eyes in an endocrine exam is Graves' eye disease. It's a sort of very common thing and something that you'll actually see in clinical practice, whereas a few of these signs are slightly more rare. So Graves' eye disease causes lid lag. So this is when they look down. Normally when someone looks down, their upper eyelid would follow their eye. Whereas in Graves' eye disease, the sort of eyelid stays, retracts, and sort of moves down more slowly than you'd normally expect. You've got lid retraction, so it's sort of the upper lid is pulled back more than normal. And then you've got exophthalmos, and you can also, in more severe cases of Graves' eye disease, get ophthalmoplegia. So just in this image here, The image on top is something sort of more indicative of Graves' eye disease, where you can see the eyes sort of bulging out, compared to the image below, which is sort of obviously what you'd more normally see with the eyes. And then we've got, in diabetes, you can get retinal changes, which I'll show you in a slide's time, and then also xanthelasma. So this is this yellow sort of deposits around the eye. So what does this image show? So this is related to diabetic eye disease.
Is that retinopathy?
So it's a treatment that you give. So this is laser photocoagulation. So I'll just go onto it on this slide. So in diabetic retinopathy, there are various stages. So in background retinopathy, you get the microaneurysms and the hard exudates. So just on this first image, it's a little bit tricky to see the microaneurysms, but they sort of look like sort of little red dots. And then the hard deposits are these sort of yellowy areas here. And then you can progress, if it's not controlled, to pre-proliferative or non-proliferative diabetic retinopathy. So this is where you also get the dot hemorrhages, which are sort of the slightly larger red dots, and also the cotton wool spots, which I think there's some here. And then if it progresses further, then you get proliferative. So this is when your eye actually starts forming new blood vessels, which is very damaging to the eye. And that's when it starts to sort of impair your vision. So to go back to my previous question, the treatment, if you start getting proliferative diabetic retinopathy, is laser photocoagulation. And the way that you can tell is it's quite, if I just go back to it, it doesn't sort of look like a process that the body might do because of its distribution, and it's quite sort of regular, and it's very carefully done. And the purpose of the photocoagulation is to stop the neovascularization progressing further and causing further damage to eyesight. And in an ideal world, you sort of wouldn't get any of this diabetic retinopathy at all. And that would obviously be achieved by sort of good glycemic control and sort of just well controlling your diabetes. So that was just a little bit on diabetic retinopathy. Obviously, you do this as part of a sort of full eye exam. But just something to be aware of. So which condition causes gum hyperpigmentation? Anyone? Okay, so this is Addison's disease, can cause gum hyperpigmentation. So yeah, we've done the mouth, done the eyes. So now just moving on to the mouth. So in Addison's, you can get gum hyperpigmentation, which is the image shown here, which is sort of darkening around the gums. Because also in Addison's, you can get the sort of bronzed pigmentation, which is often how it's diagnosed, but it can also occur in the gums. And then also signs in the mouth that you might want to look for in acromegaly. You can get macroglossia, which just is a fancy word for meaning big tongue. And then also you can get sort of increased spacing between the teeth. So it's just always useful to look in the mouth, just also look at their sort of general oral hygiene. And yeah, there can be some sort of good signs in there which might sort of lead you towards a diagnosis. Okay. So also at the face, you can assess for tetany. So on the right here, I hope that video is playing. You've got Trotsky's sign. Sorry if I'm pronouncing that incorrectly. So this is a sign that you can see in hypocalcemia, so sort of related to parathyroid hormone. And essentially what you do is you stimulate the facial nerve, as you can see the person's doing in this image, and that can cause twitching of the facial muscles. The other sign that you can see in tetany is Trotsky's sign. Again, this indicates hypocalcemia. So what you do is you put a blood pressure cuff on the arm and you inflate it to over the patient's sort of normal systolic blood pressure, and you actually keep it inflated for a good few minutes. And what happens is you get this carpopedal spasm of the hand and the wrist, which is doing what it shows in the photo. So sort of that forced contraction, and that's a positive sign for tetany. You wouldn't sort of necessarily always perform this, but it's a good thing to be aware of. And if you're concerned that someone might have low calcium, they're quite good sort of quick tests to do, which will just sort of assess what stage they are at if they are at risk of hypocalcemia. So then we've done everything face related. So now just moving on to the abdomen. So you can get Cushingoid signs. So as I mentioned earlier, you get this truncal obesity, and you can get these striae, so sort of the dark red striae, and people can get them incredibly badly. So just a good thing to be aware of and sort of start thinking sort of what could be causing it. It can just be caused by sort of rapid weight gain, but sort of they are linked to having Cushing syndrome. Importantly with diabetes, if the person isn't rotating their injection sites frequently enough, they can get lipohypertrophy. So this is where the fat actually hardens, and it's difficult to show. It's more easy if you sort of had the patient in front of you, but this fat in the lower area of the stomach, which is commonly where people inject, becomes hardened and sort of raised. So then they get this sort of change in appearance of their stomach. So if you do see that, or you see the early stages of that, it's really important to educate your patient on rotating their injection sites, because I think people do it out of ease, because of ease. Obviously it's much easier to access their stomach than it might be to access sort of their upper leg or something like that. But it's really important to sort of educate them on what it might progress to, even if you just want to show them a picture of what it could progress to if they don't rotate their injection sites. That might potentially be enough to sort of encourage them to rotate them. This one's less for inspection, but you can get abdominal pain and hypothyroidism. So just something to be aware of if they're sort of guarding, voluntary or involuntary, then that might sort of be an indicator. And then you can also get gynecomastia and hypogonadism or in a prolactinoma. So this is where you get sort of development of female breast tissue on a male. So that's just something to be aware of as well. So 3 hand signs of hypothyroidism. Is anyone aware? You don't have to say all 3. You can just suggest a single hand sign of hypothyroidism.
Someone saying a fine tremor?
Yeah, absolutely. Anything else? Any nail signs? Is anyone aware of?
Sweating.
Pardon?
Sweating is another one. Someone is saying.
Yeah. So I just got all them here. There's quite a lot of hand signs in endocrine conditions. So just working from the top. Again, you've got Cushing's, which can cause sort of bruising of the hands and thinning of the skin. In acromegaly, as I previously mentioned, you can get large hands. This is quite a rare one, but in pseudo hyperparathyroidism, you can get short 4th and 5th metacarpals. So that's just in the image here. So their sort of last 2 fingers will be significantly shorter. In particular, their ring finger will be significantly shorter. It's a very rare sign, but it might be something that comes up in your exams and a sort of data interpretation or something like that. So then to go back to the question, in hyperparathyroidism, you can get palmar erythema, so sort of reddening of the palms and the fingertips. You can get tremor, as you mentioned. You can get thyroid acropatchy. This looks quite a lot like clubbing, and I think can often be mistaken for clubbing, but it's sort of rounding of the nail bed and the loss of your normal fold. And then you can also get oncholysis, which is this image here, which is sort of separation of the nail from the nail bed. And this can sort of be quite distressing for patients if they don't like the way it looks or something like that. So just another thing to be aware of. Just always make sure you check the nails, because actually a lot of conditions can manifest themselves through nail signs. And then finally, you can get acanthosis nigricans. So this normally occurs in creases. So as you see here, it's in the armpit. You can also get it sort of in the neck creases as well. It's a sort of velvety type rash that occurs, and it can be due to sort of disruption in growth hormones. Just to go back to the tremor, when you assess a tremor, people have various different ways of assessing a tremor. The way that I always go for is just for someone to stick their arms out sort of straight in front of them and just to watch them. Some people say that you can put a piece of paper, if they balance their hands like that, you can put a piece of paper on top and use that to assess the tremor, because that will sort of highlight it, because you'll see the piece of paper moving. I don't always think that's necessary, but potentially if someone has a very fine tremor, then that might sort of help aid your diagnosis. So just something to be aware of and always a useful thing to do. So yeah. Okay, so yeah, we've done everything on the face, we've done trunk and arms, so now just moving on to the legs. So in Conn syndrome, you can get sort of weakness in the legs, you can get muscle cramps, and you can get reduced reflexes. I'll touch on doing a neurological exam later, but that's just something that you should be aware of. So to maybe move the legs around, see if there's any stiffness, and see if they report any pain in their legs. In hyperparathyroidism, you can get pretibial myxedema. So that's this image here. Some people sometimes describe it as sort of orange peel-like skin, and it can actually sometimes be quite tricky to differentiate from erythema nodosa. It's quite pale here, but it can become more sort of reddish. So just something to be aware of and another differential to add. And then in diabetes, you can get sort of muscle wasting of the lower leg. If you can see here, his sort of lower calf area looks a lot narrower compared to his upper calf area. And then he's also got these sort of reddish spots. So that's actually diabetic dermopathy. And that can just be a result of sort of chronic changes that occur in diabetes. So always good to have a look at the legs and have a look if there's anything else going on that might give you a sort of hint with the patient. Okay, so I've just put here extra examinations that are useful to do. Sort of, I might have mentioned before, but sort of you wouldn't generally do an endocrine examination completely by itself, because as you can probably tell, quite a lot of it's looking at specific signs and you're not really examining a system, as it were. So you'd quite often pair your sort of observations that you've made with another examination. A neurological exam, I think, is probably the most closely linked, because quite a lot of conditions can cause weakness, they can cause change in sensation, they can affect your reflexes as well, and that kind of thing. So I would always try and do, especially a lower limb neurological exam, as that will highlight changes in sensation, changes in power, and changes in reflexes. I've also just put on the bottom bitemporal hemianopia. So if you want to do a cranial nerve exam, that would highlight any changes in your visual field, any limitation in eye movements due to thyroid eye disease. And also you might pick up some sort of signs of tetany as well when you're examining the cranial nerves. So I think especially a lower limb neurological exam would be quite important. But as mentioned before, I'll go into diabetic foot exam in further detail, so not covering that quite yet. So then also cardiovascular exam, quite a lot of the endocrine conditions are linked cardiovascularly. So hypothyroidism, as well as making patients tachycardic, long term, that can cause damage and result in someone developing AF. So it's always good to sort of do an ECG, work out if there's any damage that's occurred to the heart muscle. Diabetes is obviously linked with sort of lipid dysfunction and high lipid levels. So always good to sort of look for signs of that. So as I mentioned earlier, sort of xanthelasma. It would also be useful to do a blood test for that. And then also a lot of the conditions can cause a raised blood pressure. So always good to check that and do further investigations if needed. And then finally on an ophthalmic exam. So again, check for your visual field defects, check for retinal changes, and check for any limitations of eye movements. Okay, great. So that's your sort of general examination, which I've just covered quickly. If you have any questions, just pop them in the chat and I can answer them. But again, as I mentioned, you wouldn't do it as an isolated examination. I think it's always something that you'd add on to a sort of other examinations that you might do. Okay, so just moving on to, let's go back. There we go. Thyroid examination. So I always think it's useful just to have the anatomy of the thyroid, because it can be quite tricky to feel if they haven't got an enlarged thyroid. So it's useful just to picture where it's at on the neck, just so to help you palpate it. And remember that you've got your two lobes to it, and then you've also got the isthmus, and people often don't palpate that. But anyway, we'll go into that more in palpation. So like I've mentioned before, it's good to do a general examination from the end of the bed. So look at their weight, look at their behavior and mood. Are they anxious? Do they look like they might have any signs of low mood or depression? Are they dressed appropriately for the weather? Sort of some people with hypothyroidism might be wearing sort of shorts and a t-shirt when it's snowing outside because they just feel constantly hot, or sort of the other end of the spectrum, hypothyroidism. So just things it's just useful to take in from the start. Tremor, as we've discussed previously, and sometimes a particularly large goiter can sort of affect the vocal cords and can cause hoarseness. So just something to consider. So once you've done your sort of end of the bed inspection, you can move on to a sort of closer inspection of the neck. So can you see the thyroid, or does it just look like a normal neck to you? Sort of, is there obvious sort of goiter, asymmetry, or anything like that? Is it enlarged on both sides, or is it just particularly enlarged on one side, or anything like that that might just give you a further indicator? Have they got any scars from previous thyroid surgery? Because don't forget, sort of even after thyroid surgery, quite a lot of patients will still need their thyroid monitoring and might still have sort of issues with their thyroid. So always good to look if they might have had previous surgery. And then the next two really help with your differentials. So at this point, you just want to look at the neck. You're not touching it at all, but you just want to, you can give the patient a sip of water and ask them to swallow. And then once they've swallowed, you can also ask them to stick out their tongue. And then while they're doing these movements, you want to look very closely at the neck to see if there's any movement of the thyroid in the neck, or see if there's any sort of tethering that might appear or anything like that. And then you'll repeat it again when you're palpating it. But just at this stage, you just want to look at the neck and see any changes that might occur when the patient swallows or when the patient sticks out their tongue. So I've just put a summary here of your factors that you're looking for in your general inspection, which I mentioned previously. And then here's just a summary of the changes that you'll see. So if it's a thyroid gland mass, so something like a goiter, then it will move on swallowing, but won't move when you protrude the tongue. If it's a thyroglossal cyst, then it will move both on swallowing and on tongue protrusion. And if it's a lymph node, then it won't move at all. So again, this isn't a definitive test, and certain thyroid masses might not move. So sort of if there's a thyroid malignancy, then depending on whether it's tethered or a sort of isolated malignancy, then it may or may not move. So these aren't sort of hard and fast rules, but as a general rule, these are the things that you should be considering. And I do think it's particularly useful for differentiating from a lymph node, because I think they sometimes can get confused. So if it doesn't move at all, then it's slightly more likely to be a lymph node. So just moving on to palpation now. So yeah, you want to palpate each of the lobes and the isthmus. I always think it's good to sort of work top to bottom, so sort of work from the upper edge. I've got a picture here of, yeah, so you want to use a sort of 3-finger technique. Don't sort of, they call it sort of spider legging, so don't kind of work like this, because that's not very effective. So keep your fingers together and apply pressure. Maybe warn the patient that you won't be able to see their face, so you won't be able to see if they're in pain or if they're uncomfortable. And also just say, because it can be quite uncomfortable, someone sort of feeling in your neck. So also sort of, it's useful to reassure them, say, if this feels uncomfortable or you feel dizzy at any point, just let me know and I can stop the examination, because it's really useful to have a sort of a patient that's at ease when you're doing it. So just sort of extra things to add in. So when you're feeling it, you're feeling for signs. So does it feel enlarged? Is there any symmetry or asymmetry? Is it sort of hard consistency? Is it sort of grossly enlarged? Is there any particular sort of nodular areas? And if there is nodular areas, does it cover the entire thyroid, or does it cover a particular sort of area of the thyroid? And also if there's a palpable thrill. So that's just if you feel, does it sort of, can you feel a sort of pulsation? Similar to what I mentioned before, you're going to ask them to swallow, and you're also going to ask them to protrude their tongue, and you're going to feel if there's any movement of any masses or anything like that. Also useful to do a lymph node examination while you're there, because that again will help with your differentials. I won't go through all that now because it's a separate area, but always a useful thing to do. A few extra things that you might not sort of naturally think about. Always useful to palpate the trachea, so to make sure that it's central and that it hasn't been shoved to one side by a very large goiter. And you can also percuss the sternum. So a lot of people think that the thyroid always expands anteriorly, but in certain cases the thyroid can expand sort of posterior inferiorly. And sort of expand below the sternum, so always useful to percuss the sternum for any dullness. You also then want to get your stethoscope out and listen for any bruit that might be occurring, and that's sort of it pretty much always linked to Graves' disease. It'd be rare to have a bruit that wasn't due to Graves' disease, so that's a really strong indicator actually. And then finally, you want to thank the patient, obviously, wash your hands, and if you've got an examiner or if you've got a sort of doctor that's watching you do the examination, it's useful to summarize your findings just for practice more than anything else, and sort of help you work out your differentials in your head. And then always useful to suggest any other investigations that you might want to do. So commonly sort of thyroid function test, an ECG and an ultrasound would be a sort of good starting off point. So I've just put here sort of characteristics that you might expect from different types of pathology. So a thyroid nodule or a malignancy, so that would be an asymmetry with a distinct palpable mass. It's very difficult to differentiate between a nodule and a malignancy. So you'd always want to do an ultrasound or maybe even a biopsy. But just on the examination, it'd be a distinct mass, and then you'd order your further investigations from there. In Graves' disease, it'd be quite a diffuse goiter, and you would feel a palpable thrill and potentially an audible bruit. And then in toxic multinodular goiter, it'd be widespread, irregular, with some sort of hard areas. So those are just things to bear in mind that will help with your differentials. Pardon?
There's a question.
Yeah.
Someone's asking, do you always listen to the bruit with the bell of the stethoscope?
Yeah, I think that's best. Obviously, the bell being smaller, it's useful. If it's a particularly large goiter, then sort of maybe you could use the other side, but sort of it doesn't do any harm either way, and generally it shouldn't affect your ability to hear the bruit. But I would always go for the bell if you've got one. Okay. So now just moving on to diabetic foot examination. So again, we start from the end of the bed as always. So you're looking for any gross deformity of the foot, any sort of obvious abnormality that you can see from the end of the bed. At this stage, I always like to assess their gait. Quite often people do this later on in the examination, but personally, I find that if I do it later on, then I just forget to do it. So I always do a quick inspection, then try and look at their gait. You're looking at what their stance is. Commonly, when people lose sensation in their feet, that can result in them having a broader stance and a high stepping gait, so they don't sort of trip themselves up. So that's always a useful thing to look at. And then also look at their shoes. This is actually a really useful thing to look at. First of all, look inside their shoes. If people have lost sensation in their feet, then there might be something inside their shoe that's causing them damage. I personally haven't come across it, but you talk to doctors who found sort of thumbtacks inside shoes. Someone once had sort of steel-toed shoes that they've got a rock inside and it was just sort of eroding away at their foot and they had no idea. So always useful to check that there's nothing going on inside the shoe. And then you also want to look at the soles. Some people, if they're sort of gradually developing this change in sensation, then they might use a certain area of their foot or use one foot more than the other. So the soles can actually be a really good indicator if there's any uneven wear. So then you're moving on to inspection. I always start relatively high up because, as I mentioned previously, you can get quite a lot of diabetic signs in sort of the shin area, so sort of muscle wasting, the dermopathy that I mentioned previously. So I usually start sort of at the knee and then gradually work down, and you want to look at the foot from all angles, particularly the sole of the foot, to make sure they haven't got any damage occurring or any ulcers or anything like that. And then especially the web spaces. Lots of things can get missed in the web spaces, and ulcers can commonly occur there that can then result in infections. So make sure you check between each of the toes, and then you're also looking for other signs, so sort of any peripheral cyanosis or pallor, any arterial or venous ulcers, any gangrene, any missing limbs, toes, fingers, anything like that, scars, hair loss. Venous guttering, that can occur if you have sort of venous insufficiency because the veins aren't full, muscle wasting and atrophy, and also pigmentation. These wouldn't necessarily be things that you'd need to sort of say out loud, sort of, there's no venous guttering or something like that, but useful to highlight if you do see it, but you wouldn't need to sort of list off that entire list of symptoms. Okay, so we're sort of, one of the things that you'll be looking for in your diabetic foot examination, let's get back, is Charcot's arthropathy. So this is, in the image here, you can see your normal foot with your normal arch, whereas in Charcot's, you have sort of loss of the functional joints in the foot, and you kind of have a collapse of these joints. So it becomes deformed. You have this sort of rocker bottom sort of shape of the foot, and it causes a lot of swelling, sort of distortion of the foot, because obviously it doesn't look like its normal shape. You have a lot of erythema and a loss of joint function. Sometimes it can be difficult to sort of look at the joint function in the foot because it's not, especially the midfoot, it's not a super mobile area. But even if you just sort of try and move the foot a little bit, you'll have a good idea of whether the joints in the midfoot are functional. But it's quite an obvious deformity, and just always remember to be gentle because you don't want to be doing any more damage to the foot. Okay, so now you're just moving on to palpation. So you're looking at temperature. People are at risk of infections if they're not feeling that they've got some kind of ulcer or damage occurring. So it's useful to compare each foot to one another to make sure that there's no sort of underlying infection that's going on. Make sure you compare sort of the top of each foot and also the bottom of each foot. You're looking for pulses, so normally the posterior tibialis and the dorsalis pedis. I personally would check both. Some people think there's no point in checking both, but I think it's a useful thing to do. And never forget that sort of a diabetic foot and peripheral vascular disease existing within the same foot can commonly occur together. So when you're doing the examination, you also want to be looking for sort of indicators of peripheral vascular disease. And then you're also just feeling for any bony deformity. So as I mentioned previously, have a feel to see if you can feel the sort of arches are still in place, and whether the joints in the midfoot are functional. So then neurological assessment, a really important thing to do as part of your diabetic foot examination, and sort of the absolute key thing not to miss, particularly sensation. So you generally look for soft touch sensation and vibration. So I'd use a monofilament, 10 grams. You want to just touch it to the sole of foot so that the little piece of plastic bends, and that assures that you're applying 10 grams of pressure. And this image here shows some of the pressure points that you should be checking to see if they've got sensation. So I'd normally get the patient to close their eyes and say, every time you feel me touch you with this little monofilament, please just say yes. You can do them a tester. So sometimes I put it on their chest and say, this is what it will feel like if you feel this on your feet, say yes. And then also an important thing to do is don't do the left foot and then the right foot. Do the same point on the left and then the same point on the right, because that'll help you compare. And I've had patients before where they've said yes to everything, and then you ask them at the end, but which foot could you feel better? And they'd go, oh, the right foot was definitely better than the left. which I could have sort of missed because they still had sensation, but it was just reduced in one foot. So always important to ask about whether the sensation is equal. So then moving on to vibration, you want to test vibration on sort of the bony areas of the foot. So you can see in the image here that they're putting it on the first NTP joint, and I'd normally also put it on the lateral malleolus as well, just because that's where they're sort of most likely to feel the vibration, and you don't really want to be putting it on any soft tissue. You also want to do reflexes, usually the ankle jerk reflex, where you put the tendon hammer on the Achilles to see if they have any response there. And you can also do it where you sort of hold onto the foot, you cover your, you put your fingers across the sole of their foot, and you actually hit your fingers with the tendon hammer and see if they have any response of their toes to that. You don't always have to assess power. I generally do. If you're doing a neurological assessment, you may as well do all points. So just see how the strength in their legs is, particularly the strength in their ankle joint and the strength of their big toe joint. And then finally, you want to do proprioception. So again, for this, I'd show them what it feels like with their eyes open and say, I will lift your toe up and I will lift your toe down. Don't forget to isolate the joint. So what I mean by that is to hold onto the joint with one hand and then move it, your big toe with the other hand. And then say, okay, now can you close your eyes and can you tell me whether I'm lifting the toe up or lifting the toe down? And make sure that you're holding onto either side of the toe and not holding sort of top and bottom, because that will give them more of an indicator of whether you're moving it up and down if you're holding it like that. So you want to hold it side on. And again, that will just give you a sort of general idea of how good the sensation is in their foot. So I put here, this is more sort of social, but I think they're quite important factors to look at. You need to look at how high the sensation impairment goes. So some people might just have it to the ankles, some people might have it just at mid-shin or even higher up. And that's important to consider when you're looking at sort of how it affects their life. You need to look at whether the sensation impairment puts them at risk of any damage occurring to their foot. So if it's sort of newly diagnosed, then it's really important to safety net that they no longer have sensation in their foot, and that therefore puts them at damage, at the risk of damage occurring to the foot. So really important to sort of safety net them there. And then also, does the sensation impairment interfere with their activities of daily living and mobility? Some people will probably try and sort of soldier on for as long as possible, but it is useful to ask those questions and highlight any concerns that they might have early on. And that will also help the patient sort of feel more at ease and makes them more likely to seek help if they've sort of had initial contact. So again, that's not really part of the examination, but I think it's something that's really important to do when you're assessing them, because that will help them in the long term. And then finally, sort of completing the examination, you're going to thank the patient, wash hands and document findings. It might be useful to suggest referring to a diabetes nurse so they can help them in sort of factors that I mentioned before, sort of helping adjust activities of daily living and making sure they've got all the right information. Further investigations, you could do a blood glucose monitoring or HbA1c. Likely if they've come in to have a diabetic foot review, then they've already had that, but always good to just mention it. And then further examinations, you can do a full lower limb neurological exam, and also useful to do a peripheral vascular exam and maybe even a Doppler to see how their sort of arterial perfusion is. Unfortunately, sometimes patients with diabetes have calcification of their vessels, which means that the Doppler sometimes won't be as effective. But always something to try, at least, just so you can have an idea as to whether they're also at risk of sort of vascular disease. And then finally, to finish off, I've mentioned these earlier, but again, look at their vision, any retinal changes, make sure they're rotating their injection sites and assess for any signs of hyperlipidemia or any other cardiovascular risk factors. So I think that's everything. Does anyone have any questions at all? Sorry, I'm aware that I skipped through that quite quickly. Anything else?
YouTube is questionless. I think most people understood it. Just one comment. Someone saying really useful. Thank you.
Fab. Glad you liked it.
But yeah, if anyone has any questions to Sophie, please ask. Please ask, and I'm sure she'd be happy to oblige. Yeah, YouTube is there's no questions on YouTube as well, Sophie.
Great.
So, if you wouldn't mind, could we just move on to the next slide?
Yeah.
So yeah, with that, thank you very much, Sophie, for lecturing. I found it really interesting, and yeah, hopefully all of our students watching today found it really useful, and it's something that they can incorporate into their practice. And thank you to everyone who stayed up till now for joining. Next week we have another really informative lecture. It will be on the musculoskeletal exam, and it will actually be a two-parter. So next week, on the 8th of July, we will be talking about the lower limb, and then the following week we'll be discussing the upper limb. So yeah, if you wouldn't mind moving on to the next slide, Sophie. Yeah. So here's the feedback link. If everyone could get their phones out and just scan the QR code. I will send the code in the chat as well. And also on YouTube. And yeah, so just once again, thank you everyone for joining us. Thank you, Sophie, for giving up your valuable time to teach for us. And hopefully we can have you back sometime soon as well for more endocrine related talks. And with that, hopefully everyone has got the QR code now as well. But that's all from all of us today. And thank you very much. Hope you have a nice evening. And we'll see you at the next lecture. So thank you once again, everyone.
Thank you.
Thank you. Bye.